Hello everyone, Dr. Kumar, consultant paediatric neurologist and founding fellow and member of CYP Neuro, which is an organisation dedicated to providing comprehensive expert paediatric neurology advice and developing high quality educational resources on various paediatric neurology topics. Now, we're thrilled to present the second podcast in our series on idiopathic intracranial hypertension and related conditions. We've already had a previous podcast where I and Professor Israni discussed about various causes of swollen appearance of optic discs and how they can mimic papilledema and how we can distinguish it. But we could only touch on idiopathic intracranial hypertension itself, condition, and which is still ultimately the most common cause of papilledema in children, as we've found out. So today we will dive deeper into diagnosis, differential diagnosis, treatment, and outcomes of idiopathic intracranial hypertension in children and how to avoid pitfalls and what we've learned from our experience. So again, have Professor Anil Israni, consultant pediatric neurologist and co-founder of CYP Neuro, to discuss things. So first things first, to clear up confusion in terms, because we know quite a number of terms are used still and historically for this condition. So we've heard about pseudotumor cerebri, we've heard about benign intracranial hypertension, and more recently, idiopathic intracranial hypertension. So, Professor Israni, why so many names for this condition?
Thank you, Dr. Kumar, for this intriguing question. So initially, it was observed that in many individuals who presented with classical features of insidious onset and episodic or gradually deteriorating features of raised intracranial pressure, following the investigations turned out to not have any tumor or mass lesion. And this rather mysterious entity was initially referred to as a pseudotumor cerebri. As the most sinister cause of a mass lesion was absent in this group of individuals, the term benign intracranial hypertension started getting used. However, we know that optic nerve damage and resulting partial or complete irreversible loss of vision meant that it wasn't a benign entity after all. Moreover, the impact of the symptom of headache itself and the burden of investigations and treatment meant that this seemingly benign disorder carried significant morbidity, and therefore benign intracranial hypertension was no longer considered an appropriate term. Idiopathic intracranial hypertension, shortly referred to as IIH, is the term being currently used by consensus, which to an extent also signifies our poor understanding of the pathogenesis of IIH.
Okay, so that's certainly an interesting journey of the etymology of this term, idiopathic intracranial hypertension. And I think the condition was first identified by Quincke well over 100 years ago. And as the term idiopathic implies, we still do not really know the etiology and the mechanism of how IIH is produced. So discuss some of the evolving concepts of the etiology of IIH in a future podcast. Is there anything more known about the mechanism of IIH, just briefly?
It is postulated that there is a buildup of intracranial pressure due to deranged CSF flow dynamics, mainly resulting from poor absorption at the level of arachnoid villi or the cerebral venous sinuses. More recently, the glial lymphatic system recently discovered convective flow of brain interstitial fluid and CSF from brain arteries to the veins has been implicated in the genesis of IIH. There's also increasing interest in systemic and metabolic factors relevant to obesity and insulin resistance, which have also been implicated in IIH.
Okay, yes, thanks very much for just giving a summary of some of the evolving ideas. And as I say, we'll explore this in future podcasts since it's a complicated new area. And really here today, we're discussing more the more simple and straightforward basics. So another important point to emphasize at this stage, I think, is that IIH is really a diagnosis of exclusion in a child presenting with signs and symptoms of raised intracranial pressure. In terms of the clinical diagnosis, I think we've previously discussed that the prerequisites of diagnosing IIH are an elevated intracranial pressure measured by CSF opening pressure and lumbar puncture, normal CSF constitution, and normal neuroimaging in terms of no gross structure anomaly. Now, certain cranial and systemic conditions and medications are important associations that can result in raised intracranial pressure or, in effect, a secondary IIH, but not really idiopathic by definition. So, Professor Israni, who would you suspect to have IIH? We know that we learn about as medical students that the typical phenotype in adults is the overweight female, but is it any different in children?
This is true for IIH occurring in post-pubertal young persons in the 12 to 17 years age group, where there is a striking female preponderance of around 80%. However, in prepubertal children, especially in young children below the age of 7 years, this difference does not really exist. Most prepubertal children diagnosed with IIH are not overweight and obese either. It is therefore important to have an open mind about the possibility of IIH in those children who present with constellation of features of headache, whether episodic or persistent and progressive, with or without vomiting, visual blurring, transient visual obscurations, vomiting, pulsatile tinnitus, and headache worsening with Valsalva-like maneuvers like coughing, sneezing, bending forwards, etc. Young children and toddlers may present with irritability or lethargy. Dizziness, ataxia, visual decline, and squint can also be presenting features of IIH.
Okay, thank you very much. So I think those are multiple of symptoms that we can think about, including headache and visual related problems. But also, I think it's important to mention that you can have asymptomatic presentations, which can be particularly difficult. And when you have an asymptomatic presentation, so there may have been the child may have been referred from an optometrist or an ophthalmologist with papilledema, but no obvious symptoms. This could be due to early presentation of someone who's pre-symptomatic. So if you left them long enough, they would develop symptoms. Or it could be because the child doesn't actually have true papilledema, that this is pseudo-optic nerve head drusen, as we discussed in our previous podcast. Or because they're too young to report visual symptoms or mild headache that they actually do have at this stage. And I think this is important because the young child can lose significant vision whilst remaining asymptomatic. So what are some practical tips for a neurology clinic-based initial evaluation of these children and young persons with suspected IIH?
So, clinical history and basic examination, including basic ophthalmology and neurology evaluation, remain our time tested friends. Probing for specific aspects in clinical history is crucial. Onset of headache, whether acute or insidious, pre existing migraines, trajectory of headache, whether episodic or persistent, whether static or progressive, new daily persistent headache, nocturnal headache, associated features to suggest elevated intracranial pressure like vomiting, presence of any double vision or visual blurring, even if transient. Any other neurological or systemic symptoms, medication history would help with making differential diagnosis or triggers like venous sinus thrombosis or head injury.
Yeah, I think it's interesting you mentioned about pre-existing history of migraine, because that can certainly be a cause of confusion. Migraine is so common in the general population. Now, what other features, for example, an examination may help as well?
So, examination should be goal directed and be focused to look for any clinical features of raised intracranial pressure, eye assessment, craniofacial assessment, neurological examination, and other relevant systemic examination for any clues for associated systemic problems. Typically, I start with looking at body apparatus, height, weight, and blood pressure, head circumference, particularly in younger children. I tend to look for phenotypic features of any associated endocrinology problems like hypothyroidism or Cushingoid state.
Yeah, thanks. I mean, I think the head circumference is something worth underlining here, particularly in young children, because remember at this stage, we do not know that this is not a secondary cause of raised intracranial pressure, such as hydrocephalus. Now, what about the eye and vision? I mean, we're not ophthalmologists, so what can be done in terms of eye and vision as non-ophthalmologists?
In a neurology clinical office setting, we can proceed with a basic ophthalmology assessment. I tend to start to look at the eyes in neutral position to observe for any squint. I check eye movements for any evidence of abduction weakness. I inquire with the child for any diplopia, especially at extremes of horizontal gaze. I check near and far vision. Where vision is suspicious, I check for pupillary reaction and for presence of any relative afferent pupillary defect. I offer Ishihara charts for color vision. I have occasionally picked up coincidental red-green color blindness too. I perform confrontation tests for visual field assessment in the clinic, but have personally not found it to be very helpful in the context of IIH, where the initial visual field defects tend to be more central than peripheral.
Okay. So now many children come to us from the high street optometrist with a Humphreys automated visual field test, but these can be unreliable in younger children. So I've found those types of automated visual field tests and deficits not particularly helpful myself. Now, what about the fundus examination? Can you tell us more about that?
Fundus examination is a combination of art and science and can be particularly challenging in younger children. But typically, I look for optic disc margins, the retinal vessels, any tortuosity, any presence of exudates or hemorrhages. Spontaneous venous pulsations, which appear like change in the color of the veins alternating from light to dark, is a reassuring sign suggesting that intracranial pressure is not elevated. However, venous pulsations are not easy or common to find, so its absence in isolation does not mean that intracranial pressure is elevated.
Thank you very much. Now, I don't know about yourself, but I certainly find optic fundus examination in children, particularly young children, very difficult. And I think the point of practice suggested is to dilate the pupils as they would be dilated in an ophthalmology clinic. I mean, usually we rely on the ophthalmologist to do this. More recently, there are non-mydriatic handheld cameras which have become available, and there's a number of publications suggesting that these have a good utility in being able to assess the optic fundus more reliably without having to dilate the vision. The devices are not particularly cheap at present. Is there anything else about the neurological and systemic examination pointing to specific alternative diagnoses?
A neurological examination is undertaken to specifically look for presence of any asymmetry, any cranial neuropathy, any features of meningeal irritation, any abnormal cerebellar signs, basically to look for any alternate cause for the child's symptoms. Likewise, systemic clues can be obtained on examination. I have occasionally found neurocutaneous markers, and once it turned out to be NF1, and the young person had a large meningioma, which was the reason for the increased intracranial pressure. I found striae on abdomen and fat distribution over trunk and neck, which was atypical and turned out to be Cushing syndrome, which may be a microadenoma not visible on the MRI of the brain. Some unusual syndromes like craniofacial disorders, obstructive sleep apnea with midfacial hypoplasia, Alagille syndrome, etc., can also be detected by a meticulous systemic examination and a general physical examination. Occasionally, I have found children with short stature on growth hormone or vitamin D supplementation to be having raised intracranial pressure in the context of the medications they have been taking. Fundamentally, the goals of clinical history and examination remain finding any features of raised intracranial pressure and identifying any clues towards a secondary cause like medication, infection, a mass lesion, or an associated endocrinological or genetic issue.
Okay, thank you very much. Now, we discussed in the last podcast on swollen discs what investigations ophthalmological directed investigations need to be undertaken as part of assessment of a child with swollen appearance of optic discs, like fundus photography, grading the papilledema, ultrasound B scans to look for any buried drusen, optical coherence tomography, and the rarely used invasive tests such as fluorescein angiogram.
Yes, absolutely, Dr. Kumar. Discussing with pediatric ophthalmologists and sharing the clinical suspicion is important to discuss the pre-test probability for any of these investigations. Fundus photography helps with grading papilledema more objectively and can be used as a baseline for future assessments. Visual acuity, color vision, and visual field findings need to be documented clearly. And where a suspicion of pseudopapilledema exists, as you mentioned earlier, ultrasound B scan and optical coherence tomography are useful adjuncts.
Okay, well, I mean, it's interesting you mentioned about optical coherence tomography. We didn't have this, I remember, many years ago, and this has become a term that we hear about more in recent years. So, what should we know as non ophthalmologists about OCT, as we call it in this setting?
The key merit of OCT is that it's a non invasive investigation. It is a tomogram, which means slices or cross sections of the optic disc and its surroundings are obtained, and it measures thickness and visualizes edema in some key retinal areas. It can distinguish pseudopapilledema from papilledema because it allows measurement of the retinal nerve fiber layer thickness, which will be increase in papilledema, and allows monitoring of change over time with treatment and also allows for prognosis.
Okay, thank you very much for giving a quick rundown of OCT. Certainly a complicated area which we really need the ophthalmologist's help, but is a key part initial diagnosis and monitoring of idiopathic intracranial hypertension, as well as many other neuro-ophthalmological conditions. So in terms of imaging now, let's say we've done all the optic investigations and that we've confirmed that this is papilledema. So we would now move on to neuroimaging in the investigation pathway of a child with suspected raised intracranial pressure, perhaps IH. And now, can you remind us again about the role of neuroimaging?
Yes, a CT scan of the head is often undertaken when there is an acute history, and this is to identify any alternative causes of raised intracranial pressure which need urgent neurosurgical intervention, for example, intracranial hemorrhage or hydrocephalus. However, we know that CT scan of the head can miss important causes such as posterior fossa brain tumors in children and chronic meningitis. MRI of the brain with MR venography remain the gold standard for making for excluding secondary causes of intracranial pressure in order to make a subsequent diagnosis of IIH, because this helps in excluding mass lesions as well as venous sinus thrombosis.
Okay, so now I'm sure we've both come across children with apparently normal MRI brain who have not had an MRV, and it can be difficult to get an MRV done in a timely manner. For example, if a young child will need a repeat general anaesthetic after they've already had an MRI brain. So can you remind us of what features on an MRI brain may help to point towards IIH?
On MRI of the brain, we may find dilated optic nerve sheaths, which means widened perioptic space, tortuous optic nerves, posterior globe flattening or scleral buckling posteriorly, protrusion of optic nerves in the retroorbital space, and an empty cella. Absence of these findings, of course, do not exclude IIH, and neither does presence of one or more of these features in isolation diagnose the presence of IIH. The MRV of the brain may show distal transverse sinus stenosis, but its main importance is for detecting a venous sinus thrombosis, which requires anticoagulation as well as management of intracranial pressure.
Okay, thanks very much for explaining regarding MRI brain and its value and MRV. So now we've done the optic tests and we've done the neuroimaging and we've excluded the obvious alternative causes of raised ICP. So what's next in the diagnostic pathway before concluding that we are now dealing with IIH?
As we discussed earlier, a diagnosis of IIH needs a normal CSF constitution as well as elevated opening pressure of the CSF. The objective measurement of CSF opening pressure with lumbar puncture is important, and of course, it is a range. And when it is more than 28 centimeters of water, or more than 25 centimeters of water in younger non obese children, then it is diagnostic of elevated intracranial pressure. Position of the child needs to be lateral with hips flexed. Excessive hip flexion itself can also increase the CSF pressure. When general anesthesia is used, the PCO2 needs to be in normal range to avoid hypercarbia, because hypercarbia can also increase intracranial pressure. A 1 kPa increase in PCO2 can cause a corresponding increase in CSF pressure up to 12 centimeters of water. Moreover, CSF constitution needs to be normal. But remember, the raised ICP due to a secondary inflammatory cause like a chronic meningitis, for example, may still require treatment similar to IIH.
Okay, I mean I think that's a very interesting and important point, that it's not just a single number that we need to be concerned about with the CSF opening pressure, but it is more likely a range rather than a precise cutoff value, and we need to take the context into account. Was the child under general anaesthetic? Were they being underventilated during the anaesthetic? What position were they in? Were they very heavily curled up? When we're trying to interpret these apparently raised pressures. And I've certainly seen things the other way around as well, where an apparently normal CSF pressure was associated with true raised intracranial pressure on a subsequent later lumbar puncture. But I think, broadly speaking, we can say that the higher the CSF pressure, certainly something above 35 or 40 centimeters of water, even under general anesthetic. I mean, certainly in my experience, I'm sure you as well, has generally been found as part of genuine raised intracranial pressure. Now, so let's say we've done the lumbar puncture, we've got sent off the CSF, it has a normal constitution, we've identified a raised CSF pressure above the agreed threshold, and so we're all sure now that we're dealing with IIH. Now, what are the key treatment-related principles once that diagnosis is established?
Yeah, once the diagnosis is secured, the treatment would depend on the situation. As clinicians, we need to be very careful about any impending threat to vision to the child or young person, in which case, an urgent neurosurgical consult for an urgent VP shunt or optic nerve sheath fenestration to salvage vision are warranted. We call this situation fulminant IIH. It is thankfully not common, but we have seen it even in younger children. More commonly, the visual acuity is not significantly impacted, at least initially. Where vision is not impacted, starting medical treatment and also making a medium term plan for any other comorbidities such as optimization of weight is important. Any contributing causes like medication or systemic endocrinological issues need to be investigated and treated separately.
Yeah, I mean that's important. So so just to recap, it really depends on the visual acuity, and I suppose the level of papilledema, the higher levels of papilledema at presentation, in terms of whether we're going very quickly towards a neurosurgical treatment, or we can take a somewhat more slower approach using just medication. Now, it's also worth remembering that the first lumbar puncture itself can be therapeutic. So, we often argue about how much fluid needs to be removed initially, and we may aim for a closing pressure of less than 20, or around 20 centimeters of water. But I think one rule of thumb that I've found is that 10 mils of CSF removed will reduce the CSF pressure by 15 centimeters of water. And I think in clinical practice, people have suggested removing between 10 mils and 20 mils of CSF, although really a lower amount of CSF can substantially reduce the CSF pressure. And that's because there's felt to be a positive feedback loop with the elevated ICP, so that removing a certain volume of CSF has a more persistent, lasting effect on reducing ICP. We have to remember that a substantial volume of CSF is produced per hour, so that the body's probably reproduced the volume of CSF we've removed in that lumbar puncture within an hour or half an hour. But in modern practice these days, we wouldn't just leave it at doing that single lumbar puncture and say you're now treated. So, Professor Israni, can you tell me more about the medical treatments that we would use?
Yeah, the most commonly used medication remains acetazolamide, and it's usually started in a small dose and escalated over the next 2 to 3 weeks for better tolerance. The usual maintenance dose is 15 to 20 milligram per kilogram per day in three divided doses. I advise to ensure good hydration to reduce the symptoms from any resulting metabolic acidosis. Abdominal discomfort and paresthesia are common side effects. I do not routinely undertake blood monitoring unless the child is symptomatic for acidosis, like feeling tired or having easy shortness of breath or on minor exertion. Even in those situations, I first insist on good hydration before considering any bicarbonate supplementation or reducing the dose. Metabolic acidosis is an expected side effect intrinsically linked to the carbonic anhydrase inhibitory action of acetazolamide.
Yes, I mean, I've certainly seen that type of problem with metabolic acidosis in a number of children with acetazolamide, particularly at high doses, but not even sometimes even at higher doses. So there seems to be a much inter-individual tolerance to the effects of acetazolamide. So let's say, acetazolamide is causing too many side effects. What other medications could we use?
Yeah, where acetazolamide alone is not sufficient or where it is not tolerated, topiramate is used either as a substitute or an addition. The dose is lower than what we would use for epilepsy reasons. So the typical dose used in IIH is between 1 to 3 milligram per kilogram per day. It is a weak carbonic anhydrase inhibitor. It may reduce appetite and reduce weight, which might be helpful in certain IIH associated with obesity. Again, good hydration is important to reduce the risk of nephrolithiasis that can occur with topiramate.
Yeah, I mean, it's very interesting about topiramate because, of course, it's a treatment for migraine and headache, well established in that sphere. And there are certainly studies indicating that migraine and headaches are a common persistent sequel of even well treated IH in terms of reducing the ICP and papilledema having settled, but still having persistent headaches afterwards. And interestingly, the acetazolamide does not appear to have the beneficial effects on headache, despite having a good response in terms of reducing the intracranial pressure and the optic problems. So there's a point at which topiramate may be prescribed in place of the acetazolamide after a period of time. Now, is there any other medication treatment often used for IH?
Zolamide and topiramate remain the initial medical management. Furosemide is useful as a good short term measure, especially in fulminant IIH. Fulminant IIH is a particularly rapidly deteriorating IIH where there is a rapid deterioration of vision or an impending threat to vision. Furosemide can be used in short term while awaiting a surgical procedure. Likewise, steroids have limited role and can be used in a desperate situation like fulminant IIH for those individuals who are awaiting surgical procedure which is imminent.
Okay, so we know that most people would be managed with medical treatment, and you mentioned surgical procedures like VP shunt or optic nerve sheath fenestration in the setting of fulminant IH, or where other medical treatments fail to improve ophthalmology findings. Now, I think just from my experience, VP shunt appears to be more widely used procedure than optic nerve sheath fenestration. Isn't that right?
Absolutely, Dr. Kumar. VP shunt is a more definitive CSF diversionary procedure. It assures reduction in raised intracranial pressure, although it can fail due to the compressed ventricles at times, and neuronavigation is typically required. Optic nerve sheath fenestration also helps with decompressing the pressure. However, it is less frequently used in children. A unilateral optic nerve sheath fenestration is sufficient to reduce pressure. There are some centers which undertake optic nerve sheath fenestration as a preferred procedure, but personally, I'm not aware of any head to head comparative randomized control trials comparing the two modalities, VP shunt with optic nerve sheath fenestration. Another modality that has recently gained popularity is the transverse venous sinus stenting. We know that venous sinus stenosis can be seen in individuals with IIH. It is not entirely clear if it is the cause of raised ICP or an effect of raised ICP that causes venous sinus compression. And when there is a clear measured pressure gradient across the stenotic transverse venous sinus, stenting the transverse venous sinus by an interventional radiology procedure has shown positive results in my experience.
Okay, well, I think these neurosurgical and ophthalmic treatments are a whole area in themselves, very interesting and constantly evolving with the new technologies that are available, like the stents and neuro navigation, etc. So we'll need to return to this in a future podcast interview where we can interview a neurosurgeon or an ophthalmologist regarding the specifics of these treatments. But going back, let's say we've started treatments and medication treatments and the symptoms are improving and the ophthalmologist is happy that the papilledema is reducing on their ophthalmic review. Now, what do you suggest, Professor Israni, for treatment usually? I mean, I tend to offer treatment for a minimum of 6 months and up to a year more typically. I've not seen relapses happening very often in children myself, but what's your experience?
Yes, that's my practice as well, Dr. Kumar. I often observe that the clinical symptoms of headache may persist. So can sometimes the swollen appearance of optic nerves for up to a year. I've seen the swollen appearance persisting beyond a year as well occasionally, and there is no clear guidance on duration of treatment in such cases. My practice is to continue to observe closely and have a regular ophthalmology surveillance for another year after discontinuation of treatment to look for any relapses. Overall, the literature in adults states relapse rate of around one third, but I suspect it is lesser in children without obesity.
Yes, I mean, I've found some literature on outcomes in the adult sector. The literature is somewhat more sparse in pediatrics, and certainly the adult literature suggests that they needed a longer average length of treatment, somewhat beyond a year, with a significant minority, so somewhere between 30 and 50% having relapse on or off medication. And I suspect that's probably because of the higher incidence of obesity in the adult series, although we are seeing this increasingly even in the pediatric IIH, because I think we've all realised that obesity is a critical risk factor for persistence of IIH and its severity as well.
Yeah, the presence of obesity and initial high grade papilledema or retinal nerve fiber layer thickness on OCT are two important predictors of future intractable and fulminant IIH.
Okay, so you've pointed out that headache continued to be a problem even after IH itself has been successfully treated. And you've also highlighted that the role of the ophthalmologist is in monitoring the successful treatment as well as the being key to initial diagnosis and the initial treatment. So I think we've covered a lot of ground there, and I think it's time to bring a close to the pod episode. So thank you once again, Professor Israni, for covering such a lot of ground in this significant condition of IH, because we've gone through differential diagnosis, signs and symptoms, the pathway of investigations, the standard and the more advanced treatments, and also something about the outcomes as well.
Thank you, Dr. Kumar, for sharing your experience. I hope our listeners will find this useful and informative, and I'm sure they will enjoy it as much as we have.
Yeah. So, yes, thanks for everyone for joining. And as previously, we'll have a transcript of this episode which we'll load onto the CYP Neuro Academy website, together with additional resources, including the references we used. Now, we're also planning to have a further podcast related to this topic of IAH and swollen discs because it is so important. But we will interview one of our ophthalmology colleagues to really get their take on what the ophthalmologist thinks about the treatment of IAH and swollen discs. So once again, thank you very much for joining.